All right, everyone. It looks like it's 9 o'clock. I just want to take a second to welcome all the participants to this on behalf of AAHS and myself. My name is Ryan Schmucker, and along with Kevin Chan, I'm one of the moderators here today. Welcome to this month's edition of the Global Hand in Hand series webinar put on by AAHS. This one is titled Fractures and Nonunions, a global reconstruction perspectives. And we're really excited to have an expert panel here that's assembled today to speak with you all about some really exciting topics. Our first speaker is Tobias Lutz from Lubeck, Germany. Will be speaking to us on endoprosthesis insertion in the setting of trauma and arthritis. Our next speaker you can go to the next slide, Grace, is Paco Del Pinal, an expert in fractures and non-unions. Will be speaking to us about intramedullary screws and in the treatment of these fractures, non-unions, and malunions. Um, Go ahead, Kevin.
And then we have Nick Smith from Sydney, Australia, who unfortunately couldn't be with us today with some family obligations. But he's going to present some cases that I think are going to generate a lot of self-reflection. Um, and then lastly, we have Dr. Gustavo Gomez from Argentina, who, whilst may not be talking about fingers, is going to present some very challenging cases that I'm looking forward to seeing in regards to intra-articular malunions of the distal radius.
And just a reminder to everyone, if you have questions during the talk, if you could put those in the chat, we would be appreciative and we'll address those throughout the talk. And then at the end, we'll circle back and have questions for our panelists as well. And everyone, we will get started with Dr. Lutz speaking first. So Tobias, you can go ahead and share your screen. Thank you.
Okay, here we are. Thanks so much, Ryan. Thanks, guys, for that honor inviting me to that exciting meeting here. Yeah, thanks for let me start right into yeah discussable story. As you might notice now, I recently had my time in Texas, in Austin, with some great hand surgeons over there to implement the CMC joint replacement. And it may have affected some of these slides in a while, as you can see. Okay, drop quickly into the MC1 fractures. This is, of course, MC5 a fracture, but what I want to say is, I mean, whatever you do, you can do it with K-wire or with screws or with prosthesis or whatever, but try to change something good to the patient. And this is a referral case where there's a lot of material in, but nothing has changed from the very beginning. So this is sad enough. Um, I don't think we have to talk too much about Winterstein fracture, but it sometimes comes along like a smooth ride. And there are, as you know, different ways to handle that. And there's, in my hands, there's no difference between all these uh, methods. Besides, there's recent research work about K-virus where they indicate higher infection rate than with internal implants than with the K-wire. So this might be a bit surprising or affecting your strategy. Uh, you can go direct to the fracture, which is more difficult for the excess, or you take it the other way around and have been quite good, easy excess, but an indirect access to the fracture. So whenever you sort this or your case out, it might help if you have CT scan. Okay, now to this case I want to present and share with you. This was a 76-year-old lady. She was in my office before because of pain of the CMC1 osteoarthritis. And one day she came with this on that stage, already 4 days old fracture. She was discharged from the emergency room with some advice for looking for a hand surgeon. I mean, to make it clear, this is an emergency case and should be treated soon. So what we face a dorsal dislocation of the MCP joint, and it was the previous stage already a set deformity. We face the interarticular multifragment fracture, and of course the CMC1 osteoarthritis. And also it's a difficult fracture. We have to think about like what is in our tool case. And I decided to put a primary CMC1 joint replacement. This is how it looks clinically. You can clearly see the set deformity, a huge hematoma everywhere. And I first start to fishing these fragments with this peak, go in it with the rim, and then I put the prosthesis in. So I already noticed at that stage that it is a stable construction. So I go further on. If I would have not seen that, I would change my decision, of course. This is how you precisely put in the K wires, center position. I mean, this is not a training for that, but nice to see. And this is how it comes out. It's a quite good alignment. You can see some fracture parts. You might recognize the beak, which was not resected at that stage for fear of unstableness or something. But it came out later that this, of course, will be a problem. So I decided to resect it later when the fracture was healed. So it looks like intraoperatively, you see kind of a mess of the metacarpal one, some defects, but lucky enough, this is stable as I demonstrate. This is a test head, which fits quite well. This is our original prosthesis now, with a double head. And again, before surgery, after surgery, still hematoma, of course, a unusual big incision, of course, and a good alignment. And yeah, you will see the function. This is 1 week after surgery. The function is like not that bad, but still less movement in the CMC1 joint. And of course, the more biggest problem is the MCP joint. Yeah. We have to talk about approval, of course, and you are more into that on the American side than me. But lucky enough, we have the approval now for Eden Littler 2 and 3. But of course, there is no special approval for fractures. You have an agreement to handle that in case of off-label use. But let me say there's no strict advice from my side to do it like that. But you can take it if you want as an option. I bought this smoothie a few days ago. It was a funny campaign from this company, and they said, "Yeah, I'm the first." So I wish everybody Merry Christmas, because probably we see us again next year. Thank you.
Thank you very much, Dr. Lutz. That was an incredible case. Excellent talk. Um, any questions for him can be put in the chat. And next we'll have Dr. Del Pignol with his talk. Go ahead. You're welcome to start sharing your screen. Thank you.
So good morning, everyone, or good afternoon or good night, depending on where you are. Let's see if it works. Okay, can you see this? So my talk is going to be is going to be about finger. The title was fracture non-union and malunion, but I'm going to focus on using this for with the use of cannulated headless screws. Okay, so typically the technique is very easy. That for metacarpals, for example, you just put the K wire and through that the screw, and you will get compression, and that's fracture stability is enough to allow you to move. Even in the fingers, when there is a complex injury, you can use this method of fixation. This is a patient with 3 different fractures, and with a minimal approach, we can put a 2.5 millimeter screw. I use always retrograde, and I will talk about that later. And we started, because we were flexor tendon, we started immediate protected range of motion. This is 4 weeks. This is the x-rays at 2.5 years, and this is the patient. And in more complex fractures, particularly if there is comminution, and you put the axial screw like this, you will have shortening, which is what typically happens even in the early paper of this technique. There was shortening, which is a big problem, or a problem, and that you can prevent from happening by doing what we call Y-strutting, where you use 2 K wires with different angle. And the idea of this is that one of the screws, one of the screws supports the other one and doesn't allow collapse of the reconstruction. So this patient had a complex defect on the dorsum of his hand, also had a volar injury, but this is the main defect with some fractures. Some of them are relatively simple, and this one is the more complex, which is comminuted fracture of the neck of the 4th metacarpal. For this area, we put 2 different oriented cannulated screws and a free flap, and we allow immediate range of motion. And this is the patient 6 months after the injury, and at the time that we were going to thin the free flap that we put. Okay, but has pretty acceptable range of motion. The technique, as we publish it, is also very applicable for proximal phalanx when the fracture is close to the base. Okay, this is a typical deformity. And what is important that we made clear that in the paper is that you have to go with the screw, has to, I don't know, you see my arrow, but it has to be in the base, has to touch the subchondral bone, okay, in order to create like an internal strut. And you can use that for complex fractures. This patient also has an intraarticular fracture here where the arrow is, but by putting the screw a bit away from that fracture, we could allow him to start range of motion. He was not the most reliable patient, but because he was using his hand normally for his things, but nevertheless, the fixation is strong enough to allow him to do everything, and these are 7 weeks after. So this is the original paper, and they were published some time ago, but I would like to share with you some different alternatives, okay, for comminuted fractures in the phalanges or in the metacarpals. The important thing here is that I'm going to explain you here is you have to restore the length by pulling, and then the important thing here is that you create an internal strut with your screw. Okay, so the screw is locked at the head of the neck of the metacarpal, but also you have to reach the subchondral bone in order to create supporting screw. So it's like an internal device. Okay, so for these fractures, we need a CT scan for measuring the fracture. We want to have the appropriate length in order to lock the screw into this area, but also to reach the subchondral plate. And here's the fracture. We allow the patient to start immediate range of motion. He has some more complex wounds in the palm with some neurovascular reconstructions, but he's at 2 weeks. Here's the fractures at 3 months, and here's at 6 months. Which is a good thing of not being invasive. You know, these comminuted fractures will heal because they are not devascularized by our approach. And in metacarpals also you can use this technique. And again, the idea is the same. You have to create an internal, the screw has to be locked proximally and distally in order to create a supporting column. And in this kind of type of comminuted fractures, you may use a minimal approach to reduce the fragments before you actually tighten the screw. But you see there is a minimal approach with one stitch to close that. Here's the patient at 1 week. And he's 4 years after. And you can do very, very complex fractures. Here's she at 4 months. So I'd like to also to talk about, I don't know if you are old enough to know about these Hacketal rods that they were used when I was resident for humeral fracture, which basically use K wires and you stack inside the number of K wires needed in order to give stability to the humerus fractures. And in the case of first metacarpal, because it's too wide, there are no screws that big, but you can reduce the fracture and then put through the same hole that you put 1 screw, you can put more, 2 or even 3. Okay, but it's the same hole, so you don't actually damage too much the head, but it's just a single entrance point, and you use that for putting 2 or more than 2. Okay, but the idea is that these screws get locked into the endomedullary canal and support as an internal frame the fracture. Okay, here's the patient, one of the patients at 2 weeks. You see, still with the stitch for the approach and with a full range of motion. I will talk about rotation, okay, which is one thing you have to take care of. This patient was operated elsewhere because the technique, as I will discuss, is not so easy. You have to pay attention to several things. And this patient was operated elsewhere, that apparently very well, but you see there is rotation. So I saw the patient, so this girl like 7 weeks after. So I just refracture this and refracture, mobilize it, and release a bit that screw that was set and put another one, okay, medially or unally, in order to bring the fragment more unally, the distal fragment to move it more unally. But mainly the main idea of this is to get stability, because in the endomedullary canal, these 2 screws were going to fight, and that will provide stability. Okay, stability, and then finally to tighten the other screw. Okay, and here's the patient. We allow her immediate range of motion, and here she is at 8 weeks. I will talk in a moment about rotation, which is something that shouldn't be a problem. Okay, because in malunions, rotation is quite common. Malrotation, sorry, is quite common. We published this paper some time ago, and this type of malunions, where the metacappa is quite descended, has been bothering to this patient for 8 years, but the approach was the classic approach of a plate, and so he was not very keen on that. And when he came to the office, I told him, we can do that, with a minimal approach, but just doing a wedge graft and putting a screw. We put this cancellous, okay? And so here's the patient, and the defect with approach that we use, and the screw, and range of motion 6 weeks, range of motion sometime later. And the deformity, you see now, is correction. Malrotation is also a problem, and but that's very easy to correct with cannulated screws. You need a minimal approach. Obviously you have to put aside the extensor tendon and the flexor tendon. Flexor tendon you don't need to, because it will move away, but the extensor tendon has to be protected. And with a saw, just you place one axial K-wire and do the osteotomy, and then you just advance the K-wire and lock it, okay? And the rotation is controlled by making a fist. If you make a fist, that finger is going to be in this position, okay? So in anatomical position, okay? So here's the patient with the osteotomy already compressed, okay? And the cannulated screw in, and you see the correction of the malunion, of the malrotation. And this is another case where you can see the second metacappa is rotated, or malrotated, and by just twisting with the screw, you can put it in the way that you want. We published the results here, so you can go here if you want to. And a warning, several warnings actually. This is not an easy technique, it's full of details, but once you master that, they are super easy and super convenient. The first one, I will not recommend you use this type of screws, because the idea of my technique, at least, is to be like the ender idea, is to have secondary healing, because these continuous threaded screws, they will create a lot of damage into the endomedullary canal, and every time you tighten the screw, the previous thread, or whatever it's called, is damaged. So don't do that. Another thing people is worried about the the retrograde insertion. So some people are putting the screw antegrade into the proximal phalanx, but if you put dorsally, which is the area where you should put it, or centrally, the time you make a fist, the cartilage is going to be healthy. Okay, so that area is going to be untouched. But if you put it red or anterogradely, then that area where you put the screw, the hole, is going to be always working, so it's going to be overloaded. So I would recommend you to use the original technique of putting retrograde. This is a patient 8 years. That was one of them. Okay, another important thing is the technique. I use auto-fix screws, but there are several brands now. At that time, there were not that many. And one of the problems of this screwdriver, the cannulated one, is that it's too wide. And if you insert it all the way through, you will create a very large defect. So for this, we have modified, since the beginning, actually, we modified the technique. And we use this screwdriver from Medartis, which is much thinner, but the guide inside is also for 1 millimeter. So you can use these screwdrivers, and the damage that you create is exactly 3 millimeters. Okay, so 2.5 millimeters, exactly the same size as the screw head. Okay, don't use autofix for if you want to sink your screw. And again, most of the problems I see in papers are technical ones. This is a paper where they compare, I think, plates with cannulated screws, and And the bad results, actually they put the picture, which is fantastic for me, because the bad results are, one of them is this, where the screw is not properly placed in the head. So there's loss reduction because the screw is too dorsal. And also they present some phalanges saying that there's loss reduction, but there's loss reduction because the screw is not advanced to the subchondral plate, which is what the paper says. You have to go to the subchondral plate in order to hold it. So one important thing about my talk is to underline that things that are easy, they have a lot of tricks, and they become easy once you master the trick. So don't please read carefully this original paper, because there are a lot of tricks there. Okay, and if you use those techniques, you can have good results in very complicated fractures. This is a lady of 65. You see osteoarthritis already, and in the DIP joints. So I thought that was a very bad case to put KYS, and I took the risk of putting these cannulated screws, as you see, sit in the subchondral plate. And he says 1 day after the surgery, pretty crazy on my side to put her to move, but she did very well. That's 3 years after. So I just please just take a look at the details of the techniques, not my paper, but just every paper. What about Nonunion? Well, the first case is nothing to do with the cannulated screw. It's a patient where everything was infected, and the important thing here is that if you have an infection and a joint is invaded with KYS for a long time, you have to do a radical debridement and include this fragment of the proximal phalanx. So we did a radical debridement, and if this were a long bone, you would put a vascularized bone graft. And if it is a small bone, I would recommend you using this technique of that was published 20 years ago. My God, 20 years ago, of vascularized phalanges from the toes. And this is a superb technique for getting rid of infections because it's vascularized tissue. And here's the patient 1 year after, and with a good range of motion at the level of the TIP joint. And finally, another case of cannulated screws. This is a patient who has had already 2 attempts of with plates. This is all devascularized, quite scarred. So I thought of using vascularized. We did arthrolysis of these joints, and because they were pretty stuck, we did tenolysis. We put cannulated screws, and at the same time we put like a Kyle type of osteochondral graft. This is a medial condyle with a Kyle extension, and here's the drawing. And revascularized. We allow him to start immediate range of motion, and here's the patient 1 year. Most of these patients, you lost track of them, but this patient came back at 11 years, not because he would like to have he would like to give us the opportunity to make this video, but because he also fractured another metacarpal in the meantime. And just to show you this 5th metacarpal that fractured in another accident, as to underline that 11 years after, the joint spaces are pretty well maintained. Okay, and so after this talk, this is what I see from my office. I will go there just after the talk, after they finish the session. Thank you very much. I'm gonna stop sharing this. Okay. Thank you.
Marco, there is several questions here. If you could stay on for a few more moments here. We have a couple minutes.
Yeah.
The first question is, how do you decide between a headless compressive screw versus a non-compressive screw? Because it looks like in a lot of your cases, you are using compressive type screws, like the variable pitch.
Yeah, but these screws, if you keep the tension, you maintain the length, they won't compress. Okay, So you keep the length by pulling with your other hand, you know, well, you need another guy or maybe yourself to, no, someone else to insert the screw. If you keep the length, they won't compress, you know, it will hold in position. Okay, so they won't compress that. So the key is in these comminuted fractures, I mean, I use compression when there's the fracture is, you know, a diaphyseal fracture and a clean fracture. I use compression screw, but the other ones, I actually use intramedullary, the idea of intramedullary strut inside, you know, it's like a intramedullary device that does not create compression. So you have to keep the length by pulling. Okay, make sense?
Yes, and then along a
Okay.
similar thread, you pointed at a few occasions to place the screw into the subchondral bone. I guess in many of your cases, you're putting the retrograde, so put it proximally into the subchondral bone. Why do you countersink it so much? And then the second follow-up question would be how much proximally does that screw have to end so that it is strutting it out, like you said?
Yeah, well, so you have to make fluoroscopy control because these screws are self-threaded. So they have to be you have to check in fluoroscopy not to pass the subchondral bone, but you have to go to the subchondral bone. The screw has to abut is correct, abut into the subchondral plate. Otherwise, you won't maintain the length, and the subchondral plate of the phalanx will go again into extension. So you have to go that. Case I show you from that paper of from Spanish people, it's a Spanish group, is because they don't go to the subchondral bone, and there the screw will hold everything.
What about
Make
distally,
sense?
Paco? Is there, yes, yes. What about distally, Paco? Is
Oh,
there a place where you want those screws to end
they,
distally?
they have to be they have to be into the neck of the you have to measure to end up in the neck of the endomedullary canal, because if you are too close to the metaphyseal bone of the distal part of the proximal phalanx, it won't hold. So you have to lock them into the endomedullary canal. You have to feel that this is tight. You know, make sense?
Yes.
Okay,
Are
good.
you using 2.5 screws for the metacarpal
2.5.
fractures?
Yeah.
2.5.
No,
And for
2.5 for
phalanx?
phalanx fracture. 2.5. Okay. 2.5 for phalanx. I use normally 3.0 millimeter for metacarpals. And
Okay.
for the first metacarpal, I may use 3 or 2.5, but several ones, you know, so for the same hole. Two of, okay.
Thank you.
You're welcome.
Okay, I'm going to pull up Dr. Smith's talk now, who unfortunately couldn't be with us, but he has recorded his talk for us very kindly.
Hi everybody, it's Nick Smith here from Sydney, Australia. I'm talking to you about global perspectives on outcomes and challenging cases with finger fractures and thumb fractures. Sorry I can't be present in person. I'm actually away with my family skiing. Who knew you could ski in Australia, but you can. But unfortunately the internet is pretty poor in the mountains. So I don't have a whole lot to say about global perspectives on outcomes. I suspect global perspectives are fairly uniform in that the closer you can restore the digit to normal, the better and the happier the patient will be. The main factors, if you're a patient, is to have minimal pain and to have maximal function, which generally means good motion and good strength. So one of my rules of thumb, which is probably not just mine, is that normal people prefer normal anatomy. So the closer you can achieve an anatomical reduction, the better, and the less you damage the soft tissues, the better. I would say that across the planet there will be varying levels of acceptance of abnormal, but there is always a limit. So I have done outreach work in Cambodia. I'm sure many of the audience have done outreach work too. But the limit will depend on the availability of treatment. So this child with a pretty severe Volkmann's contracture has not been able to access treatment for it, despite having an insensate hand with no intrinsic function and extrinsic scarring. So once we get there, they have access to the treatment, and all of a sudden it's all go. After we're there, usually for a week or so, then there's patients hear about it and they're coming out of the hills trying to access treatment. So people will always try to get the best result that they can. And in terms of a good result, this is something Peter Carter used to say, you know you've got a good result when the patient is happy, the surgeon is happy, and the patient and the surgeon are happy to see each other. So in terms of goals for hand injuries, especially bony injuries, anatomical reduction where possible, maximal stability where possible, and if stability can be achieved to allow early range of motion, I think that's preferable. But you also don't want to compromise the soft tissue envelope with excessive dissection unless it's absolutely necessary. So here's an example of what not to do. Here's a patient with a little finger metacarpal fracture, which probably most of us would manage without surgery. He went to see a general orthopedic surgeon who decided to do an ODIF, which Paco knows what an OIF is. That's an open internal fixation, so without the reduction. An ODIF is an open displacement of the fracture with internal fixation. So he had this big bulky plate applied with a displacement of the fracture, and when I went to revise it, found the EDC was actually under the plate, so which would account for the lack of passive flexion. So don't do that. I've been asked to put some cases together. I've put some cases together. I'm not sure if you'll get through all of them, but I tried to find some interesting ones from my practice in the last few months. The first one is in a 16-year-old right-handed high-level cricketer. He injured his left thumb MP joint when he went to catch a cricket ball and had these images. The radiographs show there's something going on with the metacarpal head, and a CT scan demonstrates, I'm not usually a fan of the 3D reconstructions, but it does show nicely that he has a articular injury affecting the volar part of the metacarpal head. So some discussion points for you guys to discuss, and then if you're interested, I've put in what I did. So now's a chance to stop the presentation and you can discuss. So what I did was a volar approach with elevation of the radial collateral ligament from the metacarpal neck that allowed access to the volar part of the joint. Then it was pretty easy to reduce the fragment, and I held it with a headless compression screw. Then repaired the radial collateral ligament with soft tissue anchors. He had a splint for 4 weeks to allow the ligament repair to heal, and then began range of motion. And this was him after 8 weeks. His MPR was 0 to 30 degrees, which was a little less than his other side, but not too bad, and he was able to return to cricket. So case 2, this is in a 57-year-old right-handed real estate agent who enjoys golfing and skiing, and he presented 6 weeks after an injury to his right thumb CMC joint with this imaging. So you can see as a Bannett's fracture with subluxation of the main part of the metacarpal, and it's begun healing already. So again, discussion points, or you may have different points you wish to discuss, and a pause. My approach was to try an arthroscopic osteotomy, which actually was possible, and that involved getting into the joint and initially mobilizing the volar fragment with a frayeur and a fine osteotome from inside out. Then the pre-positioned guide wires for a headless compression screw, stopping the guide wires at the level of the fracture, repeating the arthroscopy, reducing the fragment and advancing the wires, and then putting some headless compression screws over the top. You can see here there's a picture of the scope. It's hard to see the whole injury at once, but you can see the volar fragment, the step and the gap, and the shaver there clearing the soft tissue out of the gap prior to inserting the fraya and the osteotome. Following the mobilisation and reducing the fracture, we've inserted the wires and the screws, and this is him 4 weeks post-operative. He's regained all his range of motion. He has a little bit of swelling, but he's very happy. Case 3, here's a 55-year-old right-handed construction manager who's an occasional soccer player, and he had a left little finger DIP injury when his digit was struck by a soccer ball. The imaging plane radiographs demonstrate a articular injury with a dorsal and a volar fragment. So again, you can discuss as you wish. My approach with this was to try to stabilise or align the distal phalanx main fragment with the middle phalanx, which we did with it's not really an articular K-wire, but an intramedullary wire, and then do a closed reduction and pinning of the dorsal fragment and an open suture fixation of the volar fragment. So here we are part-way through the procedure with the intramedullary, or slightly not intramedullary in the middle phalanx, and dorsal blocking wires. And the two, it looks like wires, but they're actually hypodermic needles that we've advanced using a K-wire driver through the volar fragment, and that allowed passage of a suture through a dorsal suture button, which you can see in the lateral radiograph there, and we left that for 6 weeks, and following 4 weeks following the removal of the wires, he had an arc of about 5 to 30 degrees, but at least a congruent joint, which I thought was a success. So a hybrid approach for that, and with fairly minimal disruption, especially of the dorsal soft tissue envelope. Case 4, again, a 29-year-old right-handed call centre operator who enjoys going to the gym. OzTag, which is a kind of touch rugby. We have to grab the tag off the other player's pants. She injured her DIP joint playing OzTag 4 weeks prior to presentation. The imaging demonstrates the radiographs are more illustrative. So she's got a volar dislocation of the DIP joint with a mallet fragment. So my thinking with this is we needed to do an open volar approach to the DIP joint to allow it to become flexible, to reduce it. We did this with a volar plate release and releasing the collaterals from the head of the middle phalanx to allow the reduction. Then holding the reduction with an intramedullary wire, and then percutaneous dorsal blocking wires. And that was at 6 weeks. It's maintained the reduction. She's still in progress, so we don't have any follow-up recovery images. Case 5 is a 40-year-old right-handed police sergeant on general duties who was assaulted by a large intoxicated individual who grabbed his thumb while he was being restrained. And you can see he has a very dorsal comminuted injury of his thumb metacarpal, which I wasn't looking forward to performing surgery on. I thought it would probably be possible to achieve an improved position and stabilise it with plate and screws. So a dorsal open reduction internal fixation, and I have to admit almost an OIF. But I used from the proximal fragment a plate to the dorsal fragments and achieved some stability, and then a second plate from the distal fragment to the proximal phalanx. And the volar cortex was really badly comminuted, so I didn't bother with bicortical screws. So him at 3 months, the reduction's imperfect, but his function is excellent, and he's back to normal duties as a police officer by 4 months. Last but not least, for a little bit of Australiana. So this is a 24-year-old right-handed female station hand in Birdsville who presented 10 weeks after an injury to a right middle finger PIP joint. She noted that the joint remains radially angulated and is somewhat supinated. The reason for the late presentation is she comes from as far away as possible and still being in Australia. So that's Birdsville, 2,000 kilometres to Sydney from Birdsville. And she has this bicondylar fracture where the radial fragment is impacted and it's led to a step in the joint as well as the radial deviation. So my approach to this was to perform an osteotomy. The approach was between the lateral band and the central slip. We defined the step at the joint and then did an osteotomy using fine K-wire holes and using fluoroscopy to find the line of the malunion, and then reducing the joint as a priority, and held it with a K-wire and a fine screw. So thank you for listening. I hope your session is going well, and best regards from Sydney, Australia. Bye-bye.
Awesome. Cool. Are there any questions that we haven't addressed yet? No, I think with that, I think we're a little bit ahead of time, which is awesome. Gustavo, do you want to pull up your slides?
Yes. Okay. Can you see my screen?
Yes.
Okay, great. Okay, thank you very much for the invitation. It is an honor and pleasure to share this webinar with all of you. I was invited to talk about the management of intra-articular distal radius malunion. But at the end of the presentation, I add a finger malunion, so we can be in the same topic. So focusing especially on arthroscopic assisted treatment. Of course, this approach was initially described by Dr. Francisco del Piñal, who established the principles upon which we have continued working to further develop these techniques. I would like to divide the procedure into 4 steps. The two in the middle are performed by arthroscopy. So we start with an extra-articular osteotomy, then we go to an arthrolysis, an intra-articular osteotomy, and after that we do the fixation of the osteotomy. So we start the procedure with an open approach. We remove the casus, and after that we make an extra-articular osteotomy until the subchondral bone, and we try not to go into the joint because we can do a new damage of the cartilage because we are not seeing exactly through the open approach the cartilage. So this is the step that we have to complete under arthroscopy. So after we do the extra-articular osteotomy, we go to arthroscopy, then we do the arthrolysis, removing all the scar tissues on the intra-articular space. So we remove all the intra-articular fibrosis. We start usually from the ulnar side, and then we go to the radial side, okay? And after we remove a fibrosis band between the radius and the carpus, we can apply more traction to the wrist. And as I said before, it is better to work from the ulnar side toward to the radial side because the ulnar side usually is better preserved. So then after we remove the fibrosis tissue, we can identify the step off, and then we complete the osteotomy following the original fracture line. So we have converted the malunion in an acute fracture. So then we have to reduce the fracture, and after that we can place a plate to fix this malunion. So this is the paper that we have published last year in the techniques. Here is the case of a malunion involving the scaphoid fossa, approximately 2 millimeters, causing an impingement against the proximal pole of the scaphoid. We identify the osteotomy site under fluoroscopy guidance. However, it is also very important to review the actual CT scan images in order to see the exact direction of the osteotomy. So under arthroscopic visualization, we identify the step-off, as you can see in the video, and we advance the osteotomy along the original fracture line to avoid causing any additional damage to this cartilage. The main goal is to maintain or to keep intact the cartilage that it's still good. Okay, so then after we complete the osteotomy, we have to reduce the step-off. We can secure the fragment in the correct position, and then we go to definitive fixation. As you can see here, we still have some step-off at the dorsal aspect of the radius. So we remove this, we reduce this. Okay, and after we reduce this, we go to definitive fixation. So in some cases, we can use the implant to maintain the reduction. We secure the distal screws in the fragment, and then we place a compression screw through the proximal oblong hole, and then we can use the plate to elevate the fragment and then to rotate the plate and close the gap between the fragments. Okay, as you can see here. So this is the image control, the X-rays. And here is the coronal CT scan on the right side of the screen. You can see the final result with the correction of the articular step-off. And the axial view, you can see that we followed the original fracture line. Here is another case involving the lunate fossa, okay? And in this case, so we do the same. We follow the same steps. We advance the osteotomy through the open volar approach until the subchondral bone. We don't want to go through the subchondral bone, just until the subchondral bone. And then we move to arthroscopy. Then we complete the osteotomy from the articular space. And then we reduce the fragment and we place the plate to, in this case, a volar locking plate to fix this fragment. So this is the same case. You can see the volar approach. We advance the osteotomy until subchondral bone, as you can see here under image intensifier. So then we move to arthroscopy. We identify the step-off, and after that, we complete the osteotomy from the joint. As I said before, always you have a very nice view under arthroscopy. And after that, okay, you can see here that we have complete we release the fragment, the volar aspect of the lunate fossa. And after that, we go to definitive fixation. And you can see here that we can assess the reduction and the stability of this fragment. You can see that the probe passes smoothly across the fracture line, and so we have no step off between the fragments. And this is the final control under CT scan, as you can see at the right side of the screen. And here is another case. This is a more complex case. Okay, if we move to more complex cases, the patient had undergone a previous surgery for an intra-articular fracture distal to the watershed line. However, the plate was positioned proximal to the fracture and did not capture any of the articular fragments. So you can see here the step-offs, the gaps between the fragments in sagittal and coronal views. So we start removing the plate, of course, and then we do the extra-articular osteotomy through the volar approach. Then we go to arthroscopy, we complete the osteotomy, we reduce the fragment, and then in these cases, I like to use a volar hook plate in order to fix the volar rim of the lunate fossa. So this is the images from the case. You can see here under image intensifier the previous plate. So we remove the plate, as I said before. we do the extraarticular osteotomy until the subchondral bone, and then we proceed with arthroscopy and remove a significant amount of fibrotic tissue in order to have a clear view of the articular step-off. So after that, we can identify the step-off and the original fracture line. So then we complete the osteotomy under direct arthroscopic visualization, as you can see here. So the osteotom is going exactly through the original fracture line, so we avoid any new damage of the cartilage that is still intact. Okay. Okay, so after you complete the osteotomy, after you complete the osteotomy, as you can see here, we need to remove a lot of bone in order to get a fragment next to the other one. So in this case, I use the burr in order to remove a lot of new bone in the casus, so we can be able to do this, exactly this, to put the cartilage of the volar fragment in the same at the same level to the cartilage of the dorsal aspect, as you can see here. Okay, so of course we have some damage on the cartilage, but we were able to set the cartilage at the same level. Okay, and this is the volar rim plate and the volar hook plate, as you can see here, the post-operative image control at the right side of the screen. And you can see that even the shape of the skin of the wrist has changed, because we have correct the volar subluxation of the carpus that this patient had before the osteotomy. Okay, and the same at the lunate fossa. You can see the good correction of the gap that this patient had at the middle of the lunate fossa. Okay, and same in coronal view. You can see the nice reduction of the in this case of the scaphoid fossa, because it was an oblique fracture line. Again, this is a very complex case, because we have, in this case, a combination of an extraarticular deformity and an intraarticular deformity, and this patient had a surgery before. So what we have to see is to identify the problems. We can see that we have a dorsal tilt and we have a central depressive fragment at the middle of the scaphoid fossa. So in these cases, you can see that we have an intraarticular screw in the DRUJ. So we have, of course, first of all, to remove this previous plate. You can see here the depression at the center of the scaphoid fossa. So the planning is remove the plate. After that, we do the volar approach. And when we have the volar approach, we first we do the volar approach, of course, and after that we remove the plate. Then we do the extraarticular osteotomy, as I said before, and after that we can do like Orbey teaches to us. We can pronate the shaft of the radius. So in this way, we can have access to the middle part of the distal radius. So we do again the osteotomy until the subchondral bone without going inside the joint. After that, we reduce the shaft. We can use the plate in order to reduce the extraarticular deformity, so we can restore the volar tilt with the plate with indirect fixation, with indirect reduction, sorry. And after that, we go to arthroscopy. And under arthroscopy, we can do now the intraarticular osteotomy of this central depressive fragment. And like a window, we can elevate this fragment. And after we restore the articular surface of the radius, we can go to definitive fixation of the two central locking screw of the distal row. Okay, so this is the case. You can see the volar approach. We have removed the plate. So then we do the extraarticular osteotomy. And after we do the extraarticular osteotomy, we pronate the radius. And after that, we have access to the distal radius. And then we do the osteotomy until the subchondral bone. We use the plate to reduce the radius and the extraarticular deformity, as I said before. And then you can see that we have, again, a lot of fibrosis tissues in the middle of the central depressive fragment. So we use the shaver in order to remove this, we use the shaver in order to remove these fibrosis tissues, and then we can use a curette to remove the more tissue. And after that, we use the osteotomy to do the intraarticular osteotomy, and then to elevate these fragments so we can reduce the anatomical shape of the distal radius. Okay, you can see here the curette. We can use sometimes some bone graft in order to give more mechanical support to these little fragments. Okay, so after we reduce this, we go to definitive fixation. Okay, you can see here that we, of course, use a new volar locking plate. We have restored the volar tilt. And as you can see at the right side of the screen, we have restored the shape of the surface of the radius. And you can see that we place a screw underneath this fragment in order to maintain this fragment and to avoid the collapse of these fragments after the surgery. And you can see that we have a good shape of the surface after the surgery. So to finish, I would like to show this case because we are talking about fingers too. So this is a malunion of a fifth metacarpal, an intraarticular malunion. And as you can see here, the patient has a locking of the movement when she wants to do extension of the fifth MCP joint. So you can see that we have the step off that is locking the movement. So what we do is exactly the same. We do a little dorsal approach. We do an extraarticular osteotomy. Then we do the osteotomy until the subchondral bone. Then we place a Q wire as a joystick to this fragment. We go to arthroscopy. We complete the osteotomy through a direct view under arthroscopy. Then we use the QR to move back this fragment to its place in order to reduce the joint. And after that, we go forward with the QR to maintain the fragment in this position, and then we fix this fragment with 2 screws. Okay. So this is the case. You can see under image intensifier the step off, as you can see here. So then we do this extraarticular approach. The needle is in the middle of the joint, so we can understand where is the joint and where is the step off. So we do the extraarticular osteotomy, as I said before. And after that, we move to arthroscopy. Under arthroscopy, we place this key wire, we identify the step off. And under arthroscopy, we identify the original fracture line, and then we go with the osteotomy through this original fracture line in order to avoid any new damage of the cartilage, okay, from one side and then from the other side, okay? We have to go with the osteotomy from the ulnar side first and then from the radial side to complete the osteotomy, okay? And after we complete the osteotomy, we close the gap, we reduce the step off. So you can see here the difference between before and after the procedure, okay? And you can see that we have restored the anatomical shape of the head of the fifth metacarpal. And you can see here the 2 screws, the radial MCP portal and the ulnar MCP portal. And then you can see the final control under CT scan and the patient that is moving now very good, the fingers without any locking of the MCP joint. Okay, so in conclusion, it is important to see the cartilage status in order to define if we can do an osteotomy to save the joint. Pre-op planning is essential to plan the step-by-step approach in these patients, combining extraarticular procedures with intraarticular procedures in these hybrid surgeries. Thank you very much.
Gustavo, those are awesome cases. Chapeau. Um, there's a couple of questions here for you. Are you using any bone graft? And if you are you putting those in arthroscopically or through the open approaches?
Well, it depends on the where we have to place the bone graft. Usually I don't use any bone graft, but sometimes it's like a distal radius fracture with a lot of comminution. If you can support the articular fragments just with the screw, you don't need to use any bone graft. So in these cases, I don't use any bone graft. But if I see that I have a big hole inside the distal radius. So I would like to place some bone graft because we are talking about a non-union. So it is a very good idea to give biological support and mechanical support with bone graft. So it depends on the place, but usually I place it through the volar approach.
And then think, Ryan, did you have a question as well too?
Yeah, I was just going to ask, do you, when you're completing your intra-articular osteotomy, are you doing that mostly with the shaver, or are you actually introducing an osteotome into the joint under arthroscopic visualization and finishing your osteotomy that way?
Well, we usually, it's exactly as Francisco del Piñal showed it to us many years ago. We usually introduce an osteotomy through the portal,
Ah,
and you can see exactly from the joint, you can see where are you exactly placing the osteotomy, and you can complete the osteotomy through the articular space, but under, of course, arthroscopic visualization. Yes.
perfect.
Are
Those were
there some
awesome.
tool are there some tools, Gustavo, that you must have during one of these cases? The freer, the osteotome seem to be used pretty liberally. Anything else?
I think that just with osteotomes, you can do this and no more than that. Perhaps in some cases, you can have, I don't know, any tool you can use to press the fragment in order to reduce the step off. But usually we have to use osteotomes that has some angulation to the left, to the right side, or down, or a straight osteotomy, because it depends the direction, or it depends on the direction of the original fraction line, and it depends on the portals that you are going to use, the angulation of the osteotomy that you have to use.
There was one last question here, Gustavo, just along the lines of angle. Hopefully, we're getting the question across, but does the angle of the intraarticular osteotomy matter? How do you think about that?
Yes, I think it's one of the most important things you have to take care about it, because most of the times, if you see just the AP view of an X-ray, you can think that the step off is just in a straight direction from volar to dorsal side, and usually they have an oblique direction. So it's very important to plan the osteotomy with the CT scan, and I think that the actual view of the CT scan is very important. So in this planning, you can see if you will need some volar portals, dorsal portals, because sometimes you have to place the osteotomy through the FCR portal, or through a volar ulnar portal, or through the 6R portal, or through the 3-4 portal. It depends on the direction of the original fraction line. But of course, we change the direction and the portals and the osteotomy depending on the case, and planning with the CT scan.
Excellent. Are there any more questions from the chat or from the participants? If not, I think Dr. Chim has a few words to say to close us out, and then we'll be all set.
Great. Well, thanks, Ryan and Kevin, for moderating this webinar. I'd like to thank our speakers for the excellent talks and cases. And I'd like to thank you all for attending this series. So I organized the Global Hand in Hand series. So please look out for our next webinar, which is tentatively scheduled for October the 17th, with the theme of osteointegrated implants in amputees. And I'm also one of the program chairs for the upcoming AHS meeting. So I just like to encourage you to attend the meeting. Can you see my slide?
Yes.
Yep.
Yeah, so the AHS meeting will be in January in Miami, and our guest society will be the British Society for Surgery of the Hand. We really have a global meeting planned. We're going to have speakers from North America, South America, from Europe, from Asia, and from Australia, from all around the world. So it's going to be an excellent meeting. We also had a record number of abstract submissions this year, 737, which is the most ever for the AHS meeting. So please mark your calendars and join us for the meeting in Miami. So thank you so much. I'm going to turn it back to Ryan and Kevin to finish.
Perfect. Well, again, thank you to all of our speakers. Those were excellent talks, and thank you to all of our participants for joining this Global Hand in Hand webinar by AAHS. Everyone have a wonderful rest of your day.
Okay. Thank you. Bye-bye. Have a good day.